This is Dr. Hady Lichaa, cardiovascular specialist, presenting a case of a management of iliac stent artery migration and snaring. This is a young patient who could not rehab after a myocardial infarction due to lifestyle-limiting disabling claudication in both buttocks and thighs, which did not respond to a supervised exercise program. The CT scan prior to that revealed evidence of severe calcified stenosis in both common iliac arteries, which measured 10 millimeters in diameter, and the strategy was intravascular lithotripsy followed by covered balloon expandable stents. 10 millimeter intravascular lithotripsy balloon was used on both sides, 120 pulses on the left, 180 pulses on the right. And since the right common iliac artery was severely diffusely diseased and had to be covered in its entirety, and we did not have a 10 by 58 millimeter covered stent on the shelf, and we only had two 10 by 38 covered stents, so we decided to place a 9 by 58 millimeter covered stent on the right and a 10 by 38 on the left, then post-dilate the right with a 10 millimeter balloon. This is the kissing stent inflation that you see here, with a 10 on the left and a 9 on the right, followed by kissing balloon inflation up in the aorta at low pressure in order to really optimize the ostia. And then this was followed by a post-dilation with a 10 millimeter by 40 millimeter balloon on the right, simultaneously with the stent balloon, which was a 10 millimeter on the left. Following angiography was surprising. At this point, we noticed that the stent in the right common iliac artery has migrated and has covered the right internal iliac artery partially. And the ostium, or the proximal segment of the right common iliac artery, is now without any stents. So the first approach was to place an undersized 7 millimeter balloon inside the stent, partially inflated, and advancing this to try to advance the stent above the takeoff of the right internal iliac artery, and this did not succeed. So we decided to snare the stent from the contralateral approach. So the equipment that was chosen was a 6 French IM 100 centimeter coronary guide inside a 6 by 45 centimeter sheath, which was placed inside the 8 by 25 centimeter sheath, which was the access sheath initially. And as you see here, very important to pass the wire in looped fashion through the stent to make sure it doesn't go around the stent. And after advancing the guide catheter, the 6 by 45 centimeter sheath was very slowly under fluoroscopic guidance advanced to the proximal edge of the stent to minimize the risk of further iliac artery injury. The plan here was to wire the end snare 6 French compatible snare from the ipsilateral through the loops of the snare, and then grab that wire, and then to advance the sheath in a centered fashion to be able to access the edge of the stent appropriately. You see here that the snare is grabbing it's already within the wire. The snare catheter is advanced over the loops of the snare, and you can see this is backing up the sheath on the left side, and then the wire itself is grabbed, and this was anchored in order to advance the sheath over the snare catheter to center the 6 French sheath in the right common iliac artery from the contralateral side. So this allowed us, as you see shortly, the sheath will be placed literally right above the stent in a centered fashion. The wire disengages the snare, and this was done while the snare was closed to minimize entanglement. And this position of the sheath allowed us to center the snare, then to rotate it in a way that allowed us to grab the edge of the proximal component of the covered stent. As you see here, we grabbed the edge, the sheath is well positioned, and then after locking the snare wire into the snare catheter, the stent was very carefully pulled up with minimal resistance up to the level where it's not covering the internal iliac artery anymore, which was the goal. We did not want to pull it up all the way we needed to cover that segment with a short 10 millimeter stent. So of course the now well-positioned stent is post-dilated with a 10 millimeter balloon, and then we performed a kissing inflation of a 10 by 38 millimeter covered stent on the right, overlapping the other stent on the right, as well as a balloon on the left to minimize stent deformation on the left. As you see here, there's a small non-flow limiting dissection of the distal aortic edge. We did not think that this required another stent coverage of the aorta, and this would heal, most likely retrograde. And very importantly, the right internal iliac artery was patent in this young patient. And clinical follow-up at 3, 6, and 12 months, as well as imaging studies performed at 3, 6, and 12 months revealed widely patent stents, and clinical follow-up at 2 years revealed 2+ femoral pulses and no recurrent claudication.